Hello students. Today we will discuss about the temporomandibular joint. Now when you will see the temporomandibular joint, there are multiple things which you should know. So we will discuss only the structural part of the joint today in this class. So when you will see the temporomandibular joint, you should know that temporomandibular joint is a paired joint which is present on your right side as well as on the left side. So the temporomandibular joint present one on the each side and it allow opening and closing of your mouth, complex chewing movement, side to side movement, and this joint is also responsible when you will have the speech. Now what is the type of the joint? Now this is very commonly asked question that what type of the temporomandibular joint. So temporomandibular joint is a condylar variety, or you can say it is a bicondylar variety. So here in this area you can see that this is your temporomandibular joint. Now this is the very commonly asked question in your exam, that palpate your temporomandibular joint. So dear students, you have to understand that this is your external acoustic meatus and you have to keep your finger just in front of the external acoustic meatus, and then when you will move the mandible you are able to feel the movement of your TM joint. Clear? Now what are the articular surfaces of this temporomandibular joint? So you know that each joint is formed between the head of the mandible. So where is the head of the mandible? In this image you can see that this is the head of the mandible, and it is the second part comes from the temporal bone. Now here you can see that this is the temporal bone, and when you will see the part of the temporal bone which are contributing in the your TM joint are the articular fossa and the articular tubercle. Now where is the articular tubercle? Now here you can see that this is the articular tubercle and this is the articular fossa. So this area is contributing from the temporal bone and this area is contributing from the mandible side. Clear? So the upper articular bone is immobile while the lower bone alone is mobile. That means this part is remain fixed when you are moving the TM joint, and this head of the mandible is only mobile part of your TM joint. Now what are the special features about the articular surfaces? So the upper articular surface is concave or convex. So you are seeing this skull from below and you can see that this surface is, we are talking about, is concave or convex. Clear? So this part is concave and this part is convex. Now it is formed by the following part of the temporal bone. So what are the temporal bone parts contributing in this surface? The first is articular tubercle of zygomatic process. So this is the articular tubercle of the zygomatic process. Second is the anterior part of the mandibular fossa of squamous bone and the posterior non-articular part of the tympanic plate of the temporal bone. So my dear friends, you have to clear this concept here, that whenever you are reading the contribution of superior articular surface, you have to first look for this fissure. Now this fissure is a area which divides this whole articular surface in two parts, articular area and non-articular area. Clear? So non-articular area is behind the fissure, articular area is in front the fissure. Now what is the name of this fissure? Now this fissure is known as squamotympanic fissure. What is the name of the fissure? Squamotympanic fissure. So this is the squamous part of the temporal bone and this is known as tympanic plate of the temporal bone. And as you know that this tympanic plate is forming the anterior part of external acoustic meatus, which is triangular plate. Clear? So I am saying this again here, that the whole superior articular area divided into the two parts by a fissure. Now this fissure is known as squamotympanic fissure. This is the squamous part, this is the tympanic part of temporal bone. And the area which is anterior to this area is articular area and this area is non-articular area. Clear? So articular tubercle, this is here, anterior part of the mandibular fossa of squamous temporal, which is here. The posterior non-articular. Now this word is important. This is very commonly asked question in your exam. So this non-articular area is here. Clear? So this area is behind this fissure, which is known as squamotympanic fissure. Now what about the inferior articular surface? Now inferior articular surface is formed by this head of the mandible. Now when you will see the head of the mandible, this head is elliptical. So if you will see, it is elliptical in the shape. Clear? The second thing is that the long axis of the condyle of the mandible, these are known as condyles or the head of the mandible, is oriented mediolaterally and it is directed backward and medially. What does it mean? That if you will see the superior view of the mandible, you will realize that this point and this point is not in one plane. If I will draw a horizontal line, you can see that these two ends are not in one plane. That means the heads are directed mediolaterally. Clear? Mediolaterally means that they are directed like this. They are obliquely placed. They are directed like this. So these both side axes, if you will draw the axis and if you will join the axis, you will find an arch. An arch will form when you draw the axes of both the condyles in such a manner. So they are following the arc of a circle and this arc is passing through the anterior margin of foramen magnum. That means here should be the foramen magnum and these two arc, this axis and this axis is making a arc which is passing through the anterior margin of foramen magnum. So that you can appreciate here that this is the anterior margin of foramen magnum, this is the foramen magnum and these are the two axes which is not horizontal, they are going backward and if you will make both, you will find that this is passing through the anterior margin of foramen magnum. Clear? So when you are seeing the inferior articular surface of the TM joint, you have to understand that the condyles are elliptical and the axis which is passing through the head is not exactly horizontal, it is going backward and medially. That means it is going backward and medial direction. Clear? Now, what is the another important or special thing about these articular surfaces of TM joint? That unlike most other synovial joint where articular surfaces are covered by the hyaline cartilage. What does it mean? That if you will see the joints like your hip joint, like your elbow joint, like your knee joint, in most of the joint you will find that the ends of the bones are covered by articular cartilage which is hyaline in nature. So that is a very common characteristic feature of any synovial joint. But when we will see this synovial joint, that is temporomandibular joint, here the important thing is that the ends of the bone are covered by fibrocartilage rather than hyaline cartilage. So this is a very commonly asked question that which of the joints does not have hyaline cartilage on the ends of the articular surfaces? Answer is temporomandibular joint where the cartilage is fibro rather than hyaline. Now the joint cavity is completely divided into the upper and lower half by a intra-articular disc. Now here in this joint cavity you can see that this is the disc and you can see now that there is a gap present above the disc. Now this is the gap and you can see the gap present below the disc. Now this upper compartment is known as meniscotemporal compartment. This is temporal bone and we are considering this disc like a menisci of knee joint. So this compartment is known as meniscotemporal compartment and this compartment is known as meniscomandibular compartment. So the upper compartment is meniscotemporal and the lower compartment is meniscomandibular compartment. Now this is again the very important question for your exam. Describe the supports of temporomandibular joint or ligaments of temporomandibular joint. So when we are writing the ligaments, there are two types of the ligament, fibrous capsule or the capsular ligament and the supporting ligament that are known as extracapsular ligament. So the extracapsular ligament are lateral temporomandibular ligament, sphenomandibular ligament, stylomandibular ligament and pterygomandibular ligament or raphe. So let's discuss these one by one. First is the capsule of TM joint. Now dear students, when you will see the capsule, you have to understand the upper attachment and lower attachment of that capsule. So the fibrous capsule attached above. Now what is the upper attachment? So above it attached to the articular tubercle, then the circumference, that means the margin of the mandibular fossa in front, and to the squamotympanic fissure behind. So if you will see this image, and if you have to draw the attachment of the capsule, so we will start the upper attachment from the articular tubercle. So this is the articular tubercle. So first, this is the one attachment. Second is the circumference of mandibular fossa. So it will attach on the circumference of mandibular fossa. But when you will see the posterior attachment, it is very important. Why? Because you have to keep this thing in mind that this squamotympanic fissure separates or divides the articular and non-articular part of the mandibular fossa. And we know that this fissure is the main landmark, so your capsule will attach on the fissure. Now, by attaching this capsule on this fissure, you can see that this part automatically become the area behind or outside the capsule. So this part is not included in the capsule of TM joint, and that's why it is known as non-articular surface. And the posterior attachment of the capsule approaches this fissure, and that's why this area is the articular surface of the temporomandibular joint. So when you will see the mandibular fossa, this fossa is divided into the articular and non-articular part by this fissure. But my dear students, you have to understand that this fissure provide attachment to the capsule. Now this is very, very important question, that this fissure provide attachment to the fissure, which is known as squamotympanic fissure, and the area anterior to the fissure is articular and area behind the fissure is non-articular. That's why the capsule of your TM joint posteriorly attached to this fissure, which is known as squamotympanic fissure. Now, when you will see the lower attachment of the capsule, it is very simple to understand that it encloses the neck of the mandible. Now, there is one more important thing, is that anteriorly it blend with the tendon of lateral pterygoid muscle. Now this is the question of your exam. So many times you have this question. So what is the meaning of this part? So if you will see this image, now in this image what you are able to understand, that this is the lateral pterygoid muscle. You can see that this lateral pterygoid muscle. Now this is your capsule. Now here you can see that this is the outer part of the capsule. Now anteriorly this capsule is receiving the fibers, and these fibers are fibers of lateral pterygoid muscle. When you will see the insertion of lateral pterygoid, you know that lateral pterygoid insert on this depression on the neck, which is known as pterygoid fovea, but along this pterygoid fovea, the fibers will merge or blend with this anterior part of the capsule of temporomandibular joint. Now, the capsule is loosely attached in upper part. Now, which upper part? That means above the disc, and it is tightly attached in the lower part. That means here in this diagram, you have seen that there is an intra-articular disc. So, where is the disc? Now, this is the disc. Now, this disc is also getting attachment to the inner side of the capsule, and this disc is dividing the capsule in two parts. One is the upper part of the capsule. So, this is the upper part of the capsule, and this is the lower part of the capsule. Now, when you will see the tightness, you will find that it is different. So, above the disc, it is loose. Now, this is the very commonly asked question. So, it is loose in this part. So, this part of the capsule above the disc is loose, and this part of the capsule that is below is tight in nature. Clear? Now, the second question comes regarding the lining of your synovial membrane. Now, why it is important? Because it is not a usual covering or the inner lining like any other synovial joint. Now, when you will see the TM joint, you will realize that this synovial membrane lines only the inner side of your capsule. Now, here you can see that this is the inner side of the capsule, where you will find the lining of synovial membrane. The synovial membrane is not lining this fibrocartilage, synovial membrane is not lining this fibrocartilage, and synovial membrane is not lining the disc. Are you getting this? that the synovial membrane lines only the inner aspect of fibrous capsule and the neck of the mandible, but it is not lining the articular surfaces, that means the fibrocartilages, and it is not lining the disc. So this is the important thing to understand, because this is different from any other classical synovial joint. Now, the next is the extracapsular ligament. The first is the lateral temporomandibular ligament. As the name itself suggests, that this ligament is present in the lateral aspect of the joint, and it is a ligament which reinforces and strengthens the lateral side of the capsule, and the fibers are directed backward. Now, this is what you have to understand. When you will see the lateral view of your joint, you can see that this green color band is the ligament, and this ligament is not vertically straight. You can see that the ligament is going downward and backward. So what is the upper and lower attachment? When you will see the upper attachment, this upper attachment is on the articular tubercle of zygomatic process. And when you will see the lower attachment, the fibers are going downward and backward, and they will attach to this posterior side of the neck of mandible. Clear? So this is the important thing, and it has very important role that it prevents the dislocation of the joint, because it is a very thick and strong ligament present on the lateral aspect of TM joint. Then the next supporting ligament is sphenomandibular ligament. Now this is again an accessory ligament, and this ligament lies in a very deeper plane away from the joint of temporomandibular area, but it is seen in the infratemporal fossa. Now when you see from below, you can see that this region is known as infratemporal fossa, which lies on the inner side of this joint. Now here you can see that this is the head of mandible, and you can appreciate this is the capsule of the TM joint. So this ligament is deep to the inner side of your TM joint, and this area is known as infratemporal fossa. Now as the name itself suggests, that it is a connection between the sphenoid bone and the mandible, that's why it is known as sphenomandibular ligament. So when you will see the base of his skull, you will find a small projection of the sphenoid bone. This is known as spine of sphenoid. Now from this spine of sphenoid, you will have an extension, and this extension is going downward on the inner side of the mandible, and it will attach to a bony projection is known as lingula. So this is a very important landmark. When you are having the mandible in your hand, if you will see the inner side of the mandible, there is a mandibular foramen, and just on the entry of mandibular foramen, there is a bony spike is present, is known as lingula. So this is a connection between the spine of sphenoid and lingula of the mandible, and this connection is known as sphenomandibular ligament, which you can see on both the sides. Now there are two questions about this ligament. How the ligament develops? So the answer is that it develops from the Meckel's cartilage. And what is Meckel's cartilage? It is a cartilage of first branchial arch or first pharyngeal arch, which you read in the development of head and neck. So this is the most important question, that sphenomandibular ligament develops from, answer is first pharyngeal arch cartilage, that is Meckel's cartilage, and second, it attaches to the spine of sphenoid to the lingula. Now the one more thing which you are able to see in this image, that the lower end of this ligament is pierced by the nerve to mylohyoid and the mylohyoid artery. Now here you can see that this area is punctured by these two structures. One is nerve to mylohyoid and another is mylohyoid vessels, and these are the branches of inferior alveolar nerve and vessels. Now we will move to the next ligament, is stylomandibular. Now earlier was sphenomandibular, this is stylomandibular. Now you know that stylomandibular ligament is also an accessory ligament just like the sphenomandibular, but the difference is there that sphenomandibular is a embryological remnant developed from the Meckel's cartilage, but stylomandibular is a modification or thickening of the deep fascia. Now you know that there is an investing layer of deep cervical fascia, and this investing layer, as soon as approaches this base of his mandible, it splits, and the deeper part of this fascia form the stylomandibular ligament. So it attaches above to the lateral surface of styloid process. Now here you can see that this is the styloid process. So one part of the ligament attaches to this styloid process, and the lower part of the ligament attaches to the angle of the mandible and adjacent part of the posterior border of the ramus of mandible. So you can see that at this area you are finding this lower part of the ligament. So here in this image, now you can see that this is the one point of attachment and this is the another point of attachment. And this ligament is known as stylomandibular ligament. Now in this image, you can appreciate the both ligaments. Now what is this ligament? This ligament, I told you, it is a connection between the sphenoid bone and mandible. So that is sphenomandibular ligament, and this is your stylomandibular ligament. So what is the difference between two? It is developed from the Meckel's cartilage of first pharyngeal arch, and this ligament develops from the modification of the deep fascia of neck. Now this stylomandibular ligament separates the parotid gland from submandibular gland. Now this is again the important thing to understand, that when you will see this ligament, this is your styloid process, and from the tip of styloid process, this band is going downward towards the angle of mandible on inner side, and you are seeing from the inside, and here you can see that this is your parotid gland and this is your submandibular gland. So this parotid gland lies on the outer side of the ligament and the submandibular gland is on the inner aspect of the ligament. So this is what is important sometimes, that which ligament separates the parotid from submandibular. Is it sphenomandibular or stylomandibular? Answer is stylomandibular. Clear? Now we will have the another accessory ligament is pterygomandibular ligament. Sometimes it is also known as pterygomandibular raphe. Now when you will see the pterygoid process, now you know sphenoid bone is having the medial and lateral pterygoid plates, which are the part of pterygoid process. So here we are considering the lower end of medial pterygoid plate. Now this is what you can appreciate here, that there are two plates visible. Now this is the medial plate of the pterygoid and this is the lateral plate of the pterygoid. In the same way, you will have the medial plate here and the lateral plate here. Clear? Now the lower end of this plate, which plate? Medial plate, is having a very prominent spine, is known as pterygoid hamulus. That is known as pterygoid hamulus. Now from this pterygoid hamulus, a band is going downward towards the mandible, but where? Behind the third molar tooth. Now here you can see that this is your mandibular teeth. Now behind this third molar tooth, at this point you are having a band. So now if you will see the band, this is the band which is connecting here from the hamulus to this part of the mandible, and this band is known as pterygoid hamulus. So pterygoid hamulus, this pterygomandibular ligament is attachment above to the pterygoid hamulus, and lower end is on the your mandible behind the third molar. So in this image you can appreciate that this is your pterygomandibular raphe or pterygomandibular ligament, and in upper part it is attached to the lower end of medial pterygoid plate, which is known as hamulus, while the lower end is attached to the mandible behind the third molar of your mandible. Clear? Now there is one more important thing when you are reading the temporomandibular joint, is the intra-articular disc. Now there are so many questions from the disc. The first question is that disc made up of, answer is fibrocartilage. So this disc is a example of fibrocartilage, and the disc represents the degenerative primitive insertion of lateral pterygoid muscle. Now my dear students, there are two questions related to this line. One question is that name the muscle which intra-articular part converted into the disc. What is the question? That name the muscle which intra-articular part, or I should say the intra-articular tendon, converted into the disc. Answer is articular disc of TM joint. Now when you will see the articular disc of TM joint, now this articular disc of TM joint actually represent the degenerative primitive insertion of lateral pterygoid muscle. That means this muscle is continue here till this point. So this may be the tendon of lateral pterygoid. But here this portion is converted into the disc and the muscle end at this point outside the capsule. So name the muscle which tendon converted into the disc with evolution. Answer is the tendon of lateral pterygoid muscle. That's why it is written that it is a degenerative primitive insertion of this muscle. Clear? But there is a vice versa question. What is the question? That which intra-articular disc converted into the tendon? Which intra-articular disc converted into the tendon? Answer is the intra-articular origin of a muscle of knee joint is popliteus. What is that? Popliteus. If you will see the origin of popliteus, you will find that it arises from the lateral surface of the lateral condyle of the femur, and that intra-articular tendon actually represents the disc of the joint between the fibula and lateral condyle of femur, and that joint has been now no more with the evolution. But that disc has been now become the part of the tendon of popliteus. So there are two questions. Tendon converted into the disc with evolution. Answer is the disc of TM joint. And the second question is the disc converted into the tendon with evolution. Then you will have the intra-articular origin of popliteus. Clear? So now we will come to this disc of the TM joint. So what it says that whenever you are talking about the disc of the TM joint, it is fibrocartilaginous, which represent the primitive insertion of lateral pterygoid muscle. Now this disc divides the joint cavity into the two parts. Now here you can see that this is the disc and this is the first or upper chamber and this is the lower chamber. Now this upper chamber is known as menisco-temporal compartment and the lower chamber is known as menisco-mandibular compartment. Now the disc has a concavo-convex superior surface and concave inferior surface, and these surfaces are here to accommodate the shape of respective articular surfaces. Now this area is very important for your question. When you are having the two compartment, here you can see that this is the upper compartment and this is the lower compartment. Now this compartment type of arrangement in the joint allow more movements. So the lower compartment, that means this compartment, it allow mainly the hinge movement. It allow mainly the hinge type of movements, and this upper compartment allow mainly the gliding movement. Now this is something which you have to understand whenever you are reading the mechanism of the movements of TM joint. Now this is important, that because of the articular disc, the movements which are occurring in upper and lower compartment are different. The lower part of the joint, that means this menisco-mandibular compartment, mainly allow the hinge-like of movement. There are some gliding may occur, but majorly you will have hinge-like movement. In the upper compartment, that means in the menisco-temporal compartment, you mainly have the gliding movement. Now these gliding movements are visible when you are doing the protrusion and retraction of the mandible. So when you will have the forward and the backward shifting of your mandible, you will realize that it is a gliding movement, not the rotational movement. And my dear students, here one more important thing to understand, that this gliding movement which is occurring in the upper compartment is possible because I already told you that the capsule of this upper compartment is loosely attached. And because of the loose attachment of the capsule, when the gliding will take place, when this head will go forward, what will happen? Loose attachment allow stretching of the capsule. Clear? So the upper compartment allow gliding because of the loose attachment of the capsule. Lower compartment mainly allow the hinge type of movement like opening and closing of the mouth, that is elevation and depression, along with the some gliding, but this is possible because of the tight capsule in the lower compartment. So what is the attachment of the disc around its periphery? So when you will see, it is firmly attached to the capsule at its periphery. Now anterior part of the capsule blend with the lateral pterygoid muscle. Now why the anterior part of this disc blend with the lateral pterygoid? Because I just told you that this lateral pterygoid muscle is having primitive intra-articular tendon, and that primitive tendon is represented by the disc. So this anteriorly disc blend with the capsule as well as with the tendon of lateral pterygoid muscle. Now when you will see the posterior part of the capsule, you will realize that it is split into the two lamella. Now in this picture you can see there are two lamella. One is this one and another is the lower one. Now upper lamella, again it will go and attach to the squamotympanic fissure. Now why on the squamotympanic fissure? Because again you have to understand that this fissure is dividing the fossa into the non-articular and articular part. Clear? So the upper part, that means this squamotympanic fissure is receiving the capsule of the TM joint as well as the upper lamina of the disc. The lower lamina, when you will see the attachment, it will go and it will attach on the posterior side of the neck of mandible. Now, this is again the question that when you are writing the disc, so you have to write down what type of the disc it is, what are the two compartments divided by, what is the difference between the movements in the two compartments, and the next thing is what are the parts of the disc. So for the purpose, we divide this disc into the 5 parts: anterior extension, anterior thick band, intermediate zone, posterior thick band, and bilaminar zone. So this is the disc. Now if you isolate the disc, you can see that this is the shape of the disc, where you are able to see that this is the bilaminar area, this is the upper lamina, and this is the lower lamina, and these areas, now this part of the disc is having these 4 parts anteriorly. So this is the anterior extension, then you will have anterior band, this is the posterior band, this is the intermediate area, and these are the 2 lamina of the disc. So what are the 5 parts? Anterior extension, anterior band, intermediate area, posterior thick band, and the bilaminar zone. Now, what are the functions of the articular disc? So the first function is that it divides the joint cavity into the 2 compartments. So the upper compartment provide the gliding movement, while the lower compartment provide the rotatory movement mainly along with the gliding movement. The second function is that this disc helpful in distribution of the weight across the TM joint. Why? Because it increases the surface area. So by increasing the surface area of the contact, it is helpful in the uniform distribution of the weight between when you are having the chewing or when there is a pressure transmission occurs. Then the disc prevents the friction between the articular surfaces, but obviously it acts as a cushion and it helps in the shock absorber. Then it stabilizes the condyles by filling the space between the articular surfaces. So whatever the gap is present between these 2 articular surfaces, that gap is filled by the disc, and in this way it stabilizes the joint. Then there are some proprioceptive fibers are present in the disc, and these proprioceptive fibers are helpful to regulate the movements of the mandible. Clear? So when you are writing the structure of the TM joint, you have to start from your articular surfaces, then you have to write down the ligaments of the joint, you have to explain the capsule, you have to explain the structure of articular disc and accessory ligament, and lastly you have to write down the 2 very important clinical, one is the dislocation and second is the clicking sound in the TM joint. Now when we will talk about the dislocation of the mandible, you have to first understand that mandible never dislocate posteriorly. Why never dislocate posteriorly? Because we have seen that posteriorly, first you will have this bony plate which is known as tympanic plate, and second thing, it is having a lateral temporomandibular ligament. So these 2 factors avoid its posterior dislocation. So the mandible is always having the dislocation in anterior direction. And this anterior direction dislocation occurs when there is a excessive opening of mouth is already there. That means if a person is doing a very forceful yawning, when you will have the excessive opening of the mouth at the time of yawning, and if somebody will hit on the chin, what will happen that when you are having the yawning, the head is already comes out from this articular fossa and the head is below this articular eminence. Now, in this unstabilized condition of the joint, if somebody will give the force on your chin, what will happen that this head will slip out and it will fit into this area which is known as infratemporal fossa. So, the question comes is that whenever there is a dislocation occurs, what is the direction? Answer is anterior direction. Second thing is that in which area the head will go and stuck? Answer is infratemporal fossa. Now, as a result, what will happen? Patient is not able to close the mouth. So, what is the treatment? Answer is reduction. Answer is reduction. That means placement of the head of mandible in its normal position. So, the reduction is done by the depressing the jaw with the thumb by place on the last molar teeth, and at the same time there is an elevation. So, what you have to do is you have to pass your thumb inside the oral cavity of the person and you have to press first and you have to provide the pressure on the third molar. So, what will happen when you are providing the pressure on the third molar, the mandible will go down. So, when the mandible will go down, the head which has already been stuck in this infratemporal fossa will come out from the infratemporal fossa. Then you have to push the mandible posteriorly and at the same time you just close the mandible. So, with that process, what will happen that there is a reduction of the head of mandible. So, what is the question comes from this slide? What is the direction of dislocation? Anteriorly. Second, what is the prerequisite for the dislocation? Excessive opening of the mouth. Third, if there is a dislocation occurs, then what should be the position of the head? Answer is infratemporal fossa. Now, the question comes is the treatment is the reduction, and when you are doing the reduction, you have to first apply pressure on both the side of the third molar, and this pressure downward will release the head from the infratemporal fossa. Then you have to push the mandible posteriorly with elevation of the mandible, that means closing of the mouth. The second applied is clicking sound. Now, this clicking sound and pain during the movement of jaw is a sign of the damage of articular disc. So, it occurs when there is a derangement of the fibers of articular disc. Now, why the derangement may occur? It may occur because of the overclosure or malocclusion of your mandible. So, in this conditions, what will happen? There is a damage of the fibers of articular disc, and in such conditions, patients are having the clicking sound as well as pain in the movement of TM joint. Clear? So, now at the end of this lecture, we have seen the structure part of the TM joint. I explain you the articular surfaces. I explain you why the whole mandibular fossa is not articulating. You are having the articular and non-articular parts. We have seen the different ligaments, supporting ligaments. We have seen the capsule. We have seen the structure of the disc. And lastly, I told you about the applied aspect of the joint. So, this is all for the session. Thank you.